and then we were getting into our Dickey table and trying to understand it, kind of laid out how you would use that Dickey table and what you're looking for. Understand that we will have this for our exam. So when we talk about how to read the Dickey table and what you're doing with it, you're going to look at the amount of activity that they have, the contraceptive has, and then you're picking your contraceptive based off of that number. So the idea would be is for this one, for example. So your patient will present and they will be telling you, hey, I have a history of this. So I have a history of migraine, I have a history of having cramps. If somebody had not the typical like nausea and vomiting that you have when you see someone pregnant, but if they had extensive nausea and vomiting during pregnancy because those estrogen levels went up, that could indicate, hey, they have a sensitivity to estrogen. Or if they have hypertension or preeclampsia while they're pregnant, that is also something that can indicate to you that this person is sensitive to estrogen. So the idea would be, hey, I'm going to use something that has low estrogen activity. So you'll go over here to your Dickey table, and then you can look and see all of the estrogenic activities that you have, or you can remember some of these names that are here, but I would prefer you to use the table. So you see how these are brand names. Remember, brand names can change. When you're looking at our contraceptives, the brand names that are available will vary very frequently. Like the brand names fall off very quick, and you'll see that we have another one, or you'll see we have a different generic that's available within a span of months sometimes. Like we get confused even in the pharmacy with them. So you're doing it based off of, in the pharmacy we have them based off of the estrogen levels. They're separated that way. And then again, you have these brand names that are over here. So I'm gonna already know that I'm trying to stay within as low or as possible, close to zero as I can with my estrogenic activity. Does that mean that I would use a POP? And the answer to that would be no, because my POPs are not as reliable, remember, as my combined oral contraceptives, okay? So unless this person can just absolutely, even if you pick the lowest amount of estrogenic activity and they still can't handle the estrogen, then that's when you're looking at a POP. But remember, because of my adherence in that small window that I'll have, and when we talk about POPs, you'll see this in more detail. There's a very, very small window that they have to be able to take one to be covered for their contraceptive capability, right? So a POP is not something that we love to use. Those are like for those restricted type of, like somebody has VTE risk, they're breastfeeding after they're pregnant, things like that. That's when we want to use those. Other than that, we try to stay away from them because they're not like ideal. We love our combined oral contraceptives. So if you look on here, I have different estrogenic activity. So I see some that have 13, I see some that have 14. So if you had a question about this and I'm saying, hey, this person comes in and they're telling you that they have a history of migraines, right? And you're going to say, oh, they have estrogen sensitivity. I need to pick one of the lowest estrogenic contraceptives that I have. So looking at this, I have my low estrogen, I have my low estrogen 120, those both have 13. You see your low estrogen 1.530 has 14. So just trying to understand how you would read that. Looking on the back side, these are again extended use ones. So I see that with my quartet, that one has 14. So again, that's essentially how you're reading it. You would not prescribe an emergency contraceptive as a birth control for somebody every single day, right? That's emergency, like a plan B. Their contraceptive didn't work or they weren't taking a contraceptive, that's when you would give them that. And then again with the POPs, our POPs don't have any estrogenic activity in them at all. But again, those are not preferred unless there's some type of contraindication as to why I cannot take a combined oral contraceptive, okay? So what you would be doing here is saying, hey, this patient has estrogen sensitivity, which birth control am I picking? I'm the one that has the lowest amount of estrogen. When you're looking at your progestin, same thing. So this is dealing more so with people who have like a lot of weight gain. So you have Eeyore on there, you know how he kind of looks sad, he's kind of frumpy. Kind of think about that with progestin, tired. So when you look at this, this is again, find me a contraceptive that has a low level of progestational activity. PMS, if somebody tells you that they have those PMS symptoms where they're gaining weight, they have a headache, they start to feel very sad around the time that their cycle is coming, we'll try to find a medication that has a low progestin activity in it. So again, you can go here to your chart and you'll say, all right, which ones are the following that have like a low progestin amount? And so on some of these, you see where they have 0.4. So you have your Alcons, your orthotricycline. And so looking at that, I would try to go and pick one of those options that are available to me. So again, use the names that are on here. The questions on the exam will match these brand names that are on here. And then understand when you get out, like these brand names can change. So just try to find it based on the estrogen amount. Is usually what will fall into this activity with some of your contraceptives, yes.
So just to read the Dickey chart, when you're saying like aim for low estrogen, just try to get as low as possible.
Yes.
Okay, because there won't be, unless it's a pop, there won't be zero. It's just going to be like aim for the lowest.
Correct.
Okay.
Yeah. For any of these categories, as we keep going through these next.
Try to get to zero.
Yes. Just try to get as close as you can to zero, because that means that it has a low level of that activity for that contraceptive, so that you're meeting that patient's needs, right? Because if I have progestin sensitivity and you give me one with a high level, I'm more likely to see these effects happen to that patient, even magnified now. So I have an additive effect. So they may have more weight gain now. They may be more tired, okay? So now I've given them too much. And then your androgenic activity, same exact thing. So with these patients, they're gonna have spotty or like irregular cycles or menses. They will have heavy bleeding sometimes, you'll hear. Also, people will complain of like excess hair, or the women will have excess hair. They may have acne. These are signs that they're very sensitive to androgen. So again, when we're looking at this, you have two things that you're trying to do. So you want a high level of your progestational activity and a low level of your androgenic activity to try to balance out those things, help with the appearance of their skin. If they have severe acne, then again, you're going to try to look at, there's a difference, so make sure that you're understanding. So now you're looking at a high estrogen activity level with no androgen level at all, okay? So when you look at these, you see some of your ones with androgenic activity, you see that they have absolutely none, or you're trying to go for that lowest amount possible, and then looking at your progestin levels, you can again try to pick the lowest one. So you're trying to find one that has two of those at the lowest amount possible, okay? And then if I'm definitely worried about my acne, then the highest level of estrogen, but remember, what dose do we like to stay under? 35 is like our pushing it, and most of the time we're trying to stay at 20. Like when you initially prescribe somebody, if you can be there, that's safe. We rarely use that 50 unless there's some types of like interactions with our contraceptives that's going to make that estrogen level go down. Okay, so again, I'm looking and I'm saying, all right, which one of my medications do I have that can help me in this situation? So if I'm looking at my high progestin and low androgenic, you see that I have my here my Yasmin has 0 with my androgenic, and then I'm at 1.5 when I look at my progestational activity, which is on the higher end. Okay, so then that would meet that criteria. So just again, on the exam, you'll have different brand names, and then you just go to this table and you figure out which one has the best activity for me to use for that patient. Okay, and then you just pick that in. Yes.
For that particular case, would Yaz work as well as it's 0 and androgen and only 20 for estrogen?
So you
you're not
can
going to
use
do something that's active, right?
no. So, in some people, they say that they just go through and try to remember the names, which is also up to you and fine. But if I were looking at this and I had to make a choice between the Yaz and the Yasmin on my patient, I would probably pick Yaz because, again, I'm trying to stay low on my estrogen level, right? So if you do see something like that, again, keep all of the principles in mind and start low with our estrogen, because our estrogen is the big thing that we're typically worried about, because it actually has serious side effects like our BTE side effects that we're talking about. Okay? Everybody good on this? paper and understanding how you're going to classify your patient. So make sure that you're understanding how to notice your progestin, androgen, and your estrogen sensitivities that they would have, and then you're going to go low on them until you get to this androgenic one. That's where it's kind of varying, where you have to pick one that's high and one that's low, okay, because that depends. And then your acne one, specifically, again, high estrogen, low, but again, you don't want to go too high on the estrogen because you still have to watch out for your BTEs and all those different side effects that we talked about before. Yes.
So for the histories for these, is it going to be they've had a history of being on birth control and they have these effects, or they just have a history of like these in general?
It can be just in general, or it can be when you put me on a contraceptive and these things started to happen to me. Because you could start me on something and these things could start popping up because I am sensitive and I didn't know until you started me on it. Right?
I just didn't know if someone had like, if they normally have a regular menses, like then should we be like, okay, they have androgenic sensitivity, or like?
So if I come to you, most of the time when people come to you and they are not on a contraceptive prior to seeing you, you're looking at their skin, you're getting that full history, you're getting their compliance, like what would they like to have, and then you would make a choice from there. So if I said like, hey, I'm not good with tablets, I don't want to swallow tablets, I don't want to get an injection, you're going to be like, maybe I can do an implant, or I could do an IUD, or I could do a ring. So like there's several different ways, but sometimes you will put someone on one of these and they will respond this way. They will start to have a cycle that's all over the place. They may start to have migraines, and that's how you're like, oh, they started having migraines, they're sensitive to this estrogen. I need to find something now with a low level of estrogen. Oh, now their acne is, like now they have their face that's breaking out after I put them on a contraceptive. Let me look and see if I can find something that has high progestin and low androgenic activity, because maybe they have this sensitivity that we didn't know about until we started them. So these symptoms are things that could be a history or as a reaction to the contraceptive that you put them on.
So this is for changing meds then?
Both.
Okay.
Changing meds or starting a med.
Right.
Yes. Okay, our pops. We keep talking about them. When we talk about these are like a last line type of thing. We do not love them unless you have to use them, okay? Very hard for us to get our patients to be adherent when we're looking at these. So POP stands for progestin only pill, and you'll see with these that these are those medications that we talked about that are supposed to bind and inhibit the LH release. But sometimes when we're looking at these medications, they're not very effective because you have to take them within the same 3-hour window every single day. And we tell them to be very on time, because if they get anywhere outside of that 3-hour window, not only can they spot and like they'll start to have breakthrough bleeding, but they can also become pregnant in that time frame. Okay, so that's why these are not like, we're not a fan. You have to have a person who is very regimented, who is going to follow directions, and they're going to take them at the same time every single day. You know how we had all of those several different packs when we were looking at our combined oral contraceptives? With this, we only have one pack that's available. It's a 28 pack, and they don't have any placebo. So they're taking them all the way through year round, okay? When we look at this, again, just understand that the effectiveness of it, because of the time that they have to take it, and also because of the mechanism of these low levels of progestins, we don't have the complete blockage sometimes of ovulation. So if that female ovulates, that means that that egg ends up getting released, and then at any point in that time, she can become pregnant. So that's why we also don't love to use a POP. Our ideal population for using these are, again, our patients who aren't great candidates for using our combined oral contraceptives because of that estrogen component in it. So when you're looking at this, if they're breastfeeding, it says for at least a month. Most of the time we'll try to stay around that, depending on what conditions they have. We try to let that mother's milk come in first if they're choosing to breastfeed before we put them on a contraceptive, but make sure that they are using a backup method, because they can become pregnant. People think like, oh, just because I had a baby, like I can't immediately get pregnant after, and you can. For your non-breastfeeding mothers who just gave birth, depending on if they have a history of BTs or not, For the most part, you can immediately start a POP, or you can start an implant. DMPAs, if they have a risk of VTEs, we try to stay away from those for a little bit longer because they can, and that's the shot, because it can sometimes, they think with studies, increase the risk of them having VTEs, because you're hypercoagulable after you have a baby, and while you're pregnant, your coagulation factors and everything are, you're more prone to getting VTEs. So that's why we watch out with starting contraceptives after someone has had a baby, because they have that hypercoagulable state still for at least that first 42 days, is just what they found out. History of migraines, they can't tolerate estrogens, or they don't want to have estrogens. And then that CV risk that we kept talking about every time we looked at our estrogens, our black box warning, and our people who like to smoke, those are the people who we are going to like to use a POP, especially if they're telling you, hey, I'm not ready to stop smoking. Big thing that I was telling you as to why we don't like this, so the mechanism of action is essentially like, I'm just trying to make it hard for the sperm to live in this environment, and therefore it'll make it more difficult for them to get to the egg to fertilize the egg. The issue is that this varies. It is not consistent when it comes to ovulation. Sometimes that woman may ovulate, and if they do ovulate, now you have the increased risk of having that pregnancy. And if they're using the contraceptive to prevent that, that is not going to be a happy mama, okay? So make sure that you remember that, because this is a big thing when we're talking about our POPs. If you do put somebody on one of them because they have that history, try to get them off of it as soon as you can and change them to a combined oral contraceptive as soon as you can. When they stop breastfeeding, hey, are you still breastfeeding? Oh, you're not breastfeeding anymore? Let's switch you off of this POP. Let me put you on a combined oral contraceptive instead of a POP. Looking at your start methods, we have very similar start methods. So you have a quick start, first or same day start. When you're looking at the quick start, this is on any day that they want to. So they came in, they saw you, and they wanted to start their contraceptive, you can put them on it. Make sure that they have a backup method that they're using for 48 hours, unlike, how long did we say that they had to use a backup method for a combined oral contraceptive? 7 days, okay, so this is a little bit different. And then looking at your first and your same day start on the first day of the day that they started their period, and then again, they don't need that backup method. If they're breastfeeding, again, sometimes we'll have that delay, but if they're not breastfeeding, they can start taking it immediately after, depending on if they have that VTE risk or not. And then this is if you're partially breastfeeding. They're telling them to wait the 21 days or 3 weeks prior to starting the POP. What that means is you have some mothers who will want to exclusively breastfeed and they don't want their child to have formula at all. Or you'll have some who are saying, no, I'm exclusively having my child be breastfed. So if they're partially, so that means that they have formula, then you're waiting 3 weeks because you're trying to also still let that milk come in. And then 6 weeks if you're wanting them to, if they're solely breastfeeding, because that means that you need that milk to come in a lot faster and more complete. So that's why we're trying to wait 6 weeks before we put them on that contraceptive, to give their body the time to like make their milk, get their milk supply in. Because as soon as someone has a baby, that does not mean that they have breast milk right away, right? So we're trying to give their body some time to connect with the child, so for them to breastfeed the child and see how much milk supply they're gonna have. So that way when they start that POP, it's not gonna really matter. It's gonna be negligible. If I'm partially breastfeeding, you can start me earlier because I can rely on my formula, versus the mom who is gonna solely breastfeed, they don't have any formula to rely on, okay? So that's the difference between those two. Your missed dose, once you get outside of that 3-hour window, which is not a lot of time, take it immediately after, and then remember your backup method that you need to make sure that your patient knows about so that they don't become pregnant. Looking at your side effects, we see that there are several side effects. I want you to pay attention to the ones that are in bold. So irregular bleeding, spotting. Some people will have where their menses completely goes away, and then you'll have other people where they'll have it randomly come and they'll have spotting in between where they typically have it. Decrease in libido. You'll have some people where they will tell you that their skin has changed now. Weight gain is another thing, especially if someone has been on a POP for a long period of time. You see where they can gain 2 pounds. You'll see appetite changes where some people will say like, hey, my appetite went up, which connects to that weight gain, right? Because now they're eating more. Longer that they're on it also, you'll see that loss in their hair, their bone density. So again, just remember that like these are for those patients who can't tolerate an estrogen for whatever reason, or if we're worried about them breastfeeding. Looking at our advantages and our disadvantages, all I want you to understand here is that we have advantages and disadvantages to every single thing that we could potentially take. When we're talking about this, these are very good for your patients, again, who cannot handle estrogen or who do not want estrogen. These are not great because we have to follow that strict window. We also have to worry about, hey, is it blocking ovulation this month or not? So those things that we already talked about are the advantages and the disadvantages. So if you followed along on the other side, you don't have to really look at this slide too much. Okay, here are all of our different progestins that we have, and then looking at the amount of activity that they have in those progestins. So first gen, second, third, and fourth. A lot more drugs are going to start falling into this fourth gen as they continue to create them, and then maybe they will start and have a new class. But right now we're only up to fourth gen. Your progesterone is your newest one, and it's only in one, the Anavera, or that ring that lasts for a year. That's the only one that's using this progestin right now. So when we look at our first generation, remember when we talked about our progestin effects, right? We said, hey, you can have an increase in acne, you can have some weight gain, bloating, all of those things. I want you guys to remember the general activity of these things when we're looking at them, like how much estrogen activity and how much progestin and androgen activity. So our first generation, you see they're kind of all over the place. Their activity is kind of high in general in every single category that we could potentially look at. When you look at your second gen, they drop any estrogenic activity, and you see that I have quite a bit of progestin and androgen activity. The potency is also changing. So this one, your second gen, is telling you that it's more potent than your first generation, which kind of seems out of order, right? So your second and your third are very similar, and then when you look at your first, it's like your second most potent, and then your fourth gen is your least potent that you have. And you see like these are more friendly. I'm more even killed when I'm talking about my estrogen, progestin, and androgen activity. When you look at your third generation, you see that you have more progestin activity. So just kind of just general basic things that we're looking at when we're talking about these. This chart is almost telling you the same exact thing as that previous chart, right? So looking at this again, that previous chart within words. So you can look at either one of these. I think a lot of people like to look at this one because it's just cleaner and they don't have to guess about what's going on with the progestin. So up to you on which one you want to look at, but the same exact things that are going on. The one that we like to choose and the one that you're going to see used a lot is going to be your fourth gen. These are like our more modern types of progestins that we typically are going to use. Least potent, more patient friendly, a lot less side effects that we can see. And depending on the dose of the progestin and how it's given, you can see that increased risk of those VTEs happen in some of our patients with these. So looking at our fourth gen, what you see here is that there are analogs of our spironolactone, which we talked about already. When we're looking at this, you see that it's not having the same exact mechanism as what we talked about with our spironolactone. So instead of having and thinking about diuretics and those types of effects, we're looking at the fact that it's trying to help decrease the bloating that they could potentially be experiencing from that estrogen component if it is combined in a POP, in our combined oral contraceptives. Again, you see that because I have that low androgenic activity and I'm looking at these for if I have a patient who has a lot of acne and all those androgenic side effects that we talked about, balding occurring, this is a good option for us to use, those fourth gens. Looking at our interactions, again, because of the way that it's made and it being an analog of the spironolactone, we're worried about any other drugs that can increase potassium. So take your brain back to when we were talking about NSAIDs, ACE, potassium-sparing diuretics, those types of things are what I would be worried about if I had somebody who was also on a fourth gen progestin. Here are your products that have it. Again, you're gonna have your chart, but I'm not gonna just say which one has the best in it. I wouldn't have to that way, but just for you to be familiar with them, because these are the options that we will typically see used in patients who present with acne and the excess hair. Adverse effects of our contraceptives. So again, we use these a lot, but we don't think about sometimes the adverse effects, especially if we're not talking about those estrogen adverse effects. So looking at this, just understand that in that first 3-month window, if somebody is coming to you and they're complaining to you about most of the side effects, not all. If somebody is telling you like they're having, and we'll go over the signs of like aches or where we're worried about like a clot, if it doesn't sound like that and they're just coming to you and they're telling you like about breakthrough bleeding, that is normal within the first 3 months. So you're just going to tell them and keep encouraging them to stick to their contraceptive that they are on, and then you're going to wait for them to kind of wait for that time period to go by, and then if they're still bleeding after that, then you can change your contraceptive. Looking at this, waiting until 3 cycles before they kind of just go away, and then you see that your breakthrough bleeding is the most common thing that we're worried about. Remember our black box warning that we had for those cardiovascular effects and that they increase if the patient was also a smoker over the age of 35, we were definitely worried about that black box warning. These are your danger signs. So this is when you're really worried about your patient because we're not sure exactly what's going on. So the acronym is aches. So abdominal pain, chest pain, headaches, eye problems, or severe leg pain. And a lot of this is dealing with clots and like cardiovascular risk, right? So you're kind of worried about those. You're trying to make sure that there's no other underlying disease that is happening. So I definitely want you to remember your signals, remember your acronym aches. Because that is going to be our stop for our patient. Come in immediately if you're experiencing any of these signs. Looking at your return to fertility after you're talking about someone who is taking an oral contraceptive. So when anybody is on these medications, for the most part, some people will say that they have immediate return to fertility, and some people, they will say that it goes up to 6 months. But your average that you see is 2 months before someone can become pregnant. You should recommend that they need to have 3 cycles before they try to actively become pregnant, because we're just trying to make sure that that medication is out of their system. And so that people don't get discouraged. When people are trying to get pregnant and they can't get pregnant, it's already hard enough, and then you're adding on more stress. So if you tell them like, hey, let's try to let this drug get completely out of your system, let's get it down to the lowest level possible before you start. Also, nothing that will hurt your patient. They don't have to wait if they don't want to, but just tell them like, hey, just try not to count this, because every month counts, right? You kind of start getting obsessed with it. So just make sure that you're trying to help your patient along. Your prenatals, if anybody is in childbearing age, we usually try to tell them to take prenatals, but we don't want to do that every single day, especially if they don't take a multivitamin. If people take multivitamins, for the most part, I'm okay with them doing that and getting on a prenatal whenever they actually become pregnant. But it depends on the multivitamins. Some of them won't have folic acid in them. Some of them may not have DHA in them. So just depending on what it is, you switch them over after they become pregnant. But we do try to encourage that if someone is actively trying to become pregnant, then we can prescribe them a prenatal. Looking at your adverse effects. So if your patient has any of these things, this is kind of telling you like, hey, what do I do in that situation? How do I help my patient in this situation? So there's several different reasons why you can have breakthrough bleeding. First thing you're going to do is investigate why they have breakthrough bleeding. Is it because they're not taking it every single day and they keep forgetting that they need to take their pill at 7 o'clock in the morning? Because if so, then that's your problem, right? So then you need to just tell them, hey, make sure that you're taking it at the same time. If it's happening earlier in their cycle, that means that you may need to increase their level of estrogen. And if it's happening late in their cycle, that might mean that you need to increase their level of progestin. Okay? So depending on when that breakthrough is happening, that is a very important question for you to ask, because then you just go back to your table and you're like, hey, I need to increase the dose of either my estrogen or my progestin. Again, make sure that they're taking it the correct way. Your nausea and vomiting. Remember we said, hey, if somebody was experiencing a lot of that while they were pregnant, I might need to worry about my estrogen content. So if they're telling you, hey, you started to give me this medication and now I'm experiencing a lot of nausea and vomiting, one, I could look at potentially decreasing my estrogen component, but I could also say, hey, how about we switch this to you taking it at night, and make sure that you eat before, because it's not gonna really affect the absorption of your contraceptive. And when you're asleep, you're not gonna feel if you're nauseous, if you have nausea, because you're gonna be asleep, okay, by the time that medication starts to kick in. And then looking at the effects and how, again, over time, and once that 3-month period kind of hits, a lot of times people's body gets acclimated to it and they're okay, they're not worried about it, it goes away. Your acne and your hirsutism, this, remember we said, was related to that androgen, right, those androgenic effects. So again, just trying to find something that has low androgen is going to be our goal, and that's trying to help clear up their acne. Or you can also look at something that has a lower level of progestin to try to help them clear up their acne, okay? So again, just manipulating the levels of my estrogen, progestin, or my androgen is what's going to help me control my patient and the adverse effects. And always, always, always look at, am I taking the medication the right way? Hey, did you take it at the same time every day? What time did you take it? And that's the thing that you can ask them. What time are you taking your medication at every day? Oh, well, I just take it whenever I feel like it. But if you say, are you taking it at the same time every day, their automatic answer is probably going to be yes, right? So don't give them the yes or no, have them explain to you what they're doing. My drug interactions. So there are lots of different things that we say can potentially interact with a contraceptive. Some of them are things that we need to worry about, and some of them are not. So when we're looking at our inducers, these are things that we will see that we worry about. Rifampin, phenobarb, phenytoin, ethosuximide, carbamazepine, and your St. John's wort, which you'll see some people using over the counter. When we talk about antibiotics, which was a big thing that we used to say back in the day, like, hey, antibiotics, any antibiotic with a contraceptive, it could cause the patient to become pregnant because your antibiotics decrease the effectiveness of a contraceptive. There are no studies yet that have shown, hey, this is a fact, yes, this is what happens. The only antibiotic that we can find that does interact with it is rifampin. And thankfully, we don't use this a whole lot for a lot of things, okay? So this is the only antibiotic that you have that is going to interact with your contraceptives. And then we talked about this when we were talking about anticonvulsants. That's a lot of what these medications are, so just kind of remember that. In these situations, this is where you can very rarely either see a copper IUD that is then put into place, which we also don't love, or you'll see that we increase the dose of our estrogen to that 50 that we don't like to do, because it's going to decrease or induce my contraceptive anyway, so those levels are going to go down very quickly, okay? But again, you have your one antibiotic, some of your anticonvulsants, St. John's wort, that's what we're looking at. And then in these situations, you can either use your copper IUD, or you can try to use your 50 microgram dose of your estrogen. This is what I just told you about already. So rifampin, remember, is the only thing that we were worried about. If you have them on a pop or a progestin IUD or implant, also not worried about it because it only interacts with the estrogen. So this is only if they were on a combined oral contraceptive that you would be worried about these interactions. Looking at lactation, we've kind of already gone over this. So if we have someone who is planning on breastfeeding, try not to give them an estrogen or a combined oral contraceptive. If they're breastfeeding, you want to put them on a pop. Okay, so that's all this is saying. Estrogen is going to decrease the amount of milk that they have, right? So anything that contains estrogen, understand that prolactin level is going to go down, and therefore their ability to breastfeed is going to also decline. And they will try to do several things to get their supply back up, but because they have that estrogen, it's battling against it and it's not going to work, okay? So please make sure that you are being educated, because they may no longer go to OB and they will be coming into you. And if I see my breast milk production go down, I'm stopping whatever I'm taking because I'm trying to feed my child, okay? So then they're not on any contraceptive, and then they end up pregnant, and they're going to be mad about that too, right? So just make sure that at that point you know I can offer them a pop, and they can take that, so that they're protected against against another pregnancy, but they can still breastfeed their child without having a decrease in the prolactin. So progestins are prolactin friendly. Your estrogens are not. Okay? So progestins good, estrogens not good. When we're looking at how to apply these, I kind of touched on it a little bit, but this is just giving all of this to you in words. So if your patient gives birth, they want to breastfeed, you should wait at least 6 weeks for you to be able to give a pop. You can give it as soon as 21 days. There's been several different formulation things that come into play at that 21 days, but they recommend that you don't do that, right? Because we want to, again, allow that milk production to come in. So exam purposes, 6 weeks is what we're talking about for our pops. During that time, they need to make sure that they're using a backup method so that they don't become pregnant. If they are not breastfeeding and they don't have any CV risk, right? So I'm not breastfeeding, I have no risk that is increasing the chances of me having any type of VTE or anything like that. I can give them a progestin option, okay? Immediately after they give birth. I'm not worried about milk production because the mom is not breastfeeding the child. They're giving them a bottle, they're giving them their infant milk, right? So I'm not worried about prolactin. So I can immediately give them a pop. I still want to avoid my estrogen for 21 days, and that's because of the increased VTE risk with my estrogen. And because I just gave birth, remember, I'm hypercoagulable, right? So that's why we wait the 3 weeks when we're talking about our estrogen, but it's a lot quicker, and we can say, hey, now because you're not breastfeeding, estrogen is okay, because again, I'm not worried about the prolactin. I'm not worried about that decrease for that mother, okay? So avoiding estrogen, so if they want a combined oral contraceptive, they have to wait 21 days. If they want a POP or any of our other progestins, we can give those immediately after if they have no VTE risk. If they have a cardiovascular or a VTE risk, you see that we are going to want to avoid our estrogens for even longer now, right? Because they're still hypercoagulable, but I'm also trying to make sure that we are as far out as I can get. So that's why you see now the 42 days for your estrogen-containing contraceptives. Okay, so that would be a combined oral contraceptive. We would wait 42 days because they have a VTE risk. If they don't have a VTE risk, we're waiting 21 days for estrogen component, and I can immediately give them my POP. If they're breastfeeding, I want to wait 6 weeks so I can let their milk come in, and I want to try to avoid any estrogen at all for the person who is breastfeeding. Okay. Emergency contraceptives. So if I was taking birth control or I was saying that I was abstinent and then all of a sudden I was worried about becoming pregnant, this would be an option for you to give to one of those patients. There are also several other situations. So if someone was a victim of sexual assault, or if someone was trying to say, hey, I want to do the withdrawal method or like the calendar method, and they think maybe they messed up or they got the day wrong, this is also for those types of patients. It's not just for the person who is just like out living their best life, okay? That is not always what that means. So make sure that you also don't attach that stigma to emergency contraceptives, okay? Because sometimes providers will do that, or they'll be like, why are you in here again? You don't know what happened to that person unless you ask that person what happened to them. And emergency contraceptives sometimes are what are needed in some of these situations, especially if somebody did not use protection for whatever the reason may be, okay? So with this, make sure you understand it's preventing pregnancy from happening and will not terminate it. So if the pregnancy has already happened, the sperm and the egg have joined, then at that point, this will not abort that pregnancy. It's too late that they have used this, and they will find out eventually that it didn't work, okay? So that is how your contraceptives work. Some of them, they can get them over the counter, some may not be able to, we'll have to prescribe them. This is not a form of regular contraception. So if somebody continues to come to your office asking you for emergency contraceptives, you should be like, hey, let's talk about birth control. Let's get you on something that is for you to take every day, because this is not what that is for. This does come with side effects because it is a high level of that estrogen and progestin that we're trying to give them to prevent the pregnancy. So if they were consistently taking this, they would have their cycle all over the place. I used to work at a store in Miami overnight, and we had one patient, and she came in like 3 or 4 times a week. And I was like, I don't have any more to sell to you. I started to take them off of the shelf because I wanted her to go to her provider because she needed contraceptives. And she was using it just because I think she just was using it as her this is not birth control. So I did have a conversation with her. I talked to her and she's like, yeah, I don't want to take birth control if I can just take this. Also, ma'am, these are $50. Birth control is a lot cheaper than you come in and spending $50 every other day. I don't pay for it. Still not the point. Ma'am, I need you to go to the next 24-hour leave, which is not close. And she finally, ended up getting on birth control. So just again, make sure that you're having those conversations. The more time that passes from that sexual encounter, the less effective it becomes, okay? So time matters. The further out you are, the more likely it is that this will not work, okay? So that's what this is showing you here. Over time, you'll see that the effectiveness starts to increase. So this is our chart of our different options that we have for emergency contraceptives. Your copper IUD is your most effective. Issue with your copper IUD, one is going to need you to implant that copper IUD. So they're going to need to have an appointment or try to get in with you very, very quickly to see if you can give them this IUD, and they have up to 5 days to be able to do so. So this is important, that this is your most effective option that you have, and that they have within 5 days for them to get it implanted by you. This is not something that they can do themselves. Next, we have our Ella. So when you look at Ella, Ella is a great option to use, but again, they need you. They're going to need a prescription. If they are here with our program that I made, the pharmacist could prescribe one of these for them. But if not, that will require you to now prescribe them. There is a weight limit when we're talking about our Ella. So the person is supposed to be less than 195 pounds. When they did the studies for these, they didn't have anyone in their studies that were over 195 pounds. So we don't know the effectiveness of it if they're over that weight. So they have an increased risk if they're over that 195 pounds of becoming pregnant, despite them taking this Plan B or their emergency contraceptive. And then last is our Plan B, or a generic equivalent to our Plan B. You have 1 step and you have 2 steps. 1 step means they take 1 pill. 2 steps mean that they take 2 pills. Typically it's 12 hours apart. The reason why they did that is a lot of people were vomiting after they took the first one because it did not feel, I guess, pleasant. And so they would vomit, and then you didn't know how much they got in. And so now that what they did was they had the 2-step where they broke down the dose so that it's easier on the stomach for them to digest it and be able to take it. So not as fantastic to get, not as fantastic as meaning like how it feels as far as the adverse effects, but available over the counter. So anytime a pharmacy is open, that means that they can get one of these. They don't need you to do anything. The first 2 require you. Because your Ella, you needed a prescription, and your IUD, you needed to put it in. The Plan B, they can just go and buy it themselves. Another thing with the Plan B is that this also has a weight on there. So if they're over 165 pounds, we don't know the effectiveness of this one either. So when you have a patient who comes in and they're talking to you about emergency contraceptives, their weight plays a role, right? Because if I was 180 pounds, is the Plan B a good option for you? No, you can say, hey, I'm going to go ahead and prescribe you Ella, or would you like to have a copper IUD, which has no weight, they don't care, it works, it's very effective, right? So that's the difference between all 3 of these. Depends on weight, depends on the time that you have available. You also have a little bit more time when you need to take the pill with the Ella versus when you have your Plan B. Yes?
Just for clarity's sake, because it does matter to a lot of people, if you're using the copper IUD in this way and you're waiting 5 days, it would be considered more.
And you're waiting 5 days?
Like, if you're waiting 5 days and how the copper IUD is in place, you'd essentially be preventing it from, like,
You're gonna
fertilize, you'd be preventing it from getting.
So then that's something that I don't know if y'all talk about it in women's health or not. Depends on what you define as like a pregnancy,
Yeah,
right? But you're also gonna check. You're gonna check first to make sure what's happening as well. You're not just gonna go in and say, I'm gonna implant this copper IUD, right? So don't ever do that. In anything that you're implanting, whether it's an IUD, copper, hormonal, whatever, you're always going to do an exam before you do that. But that topic as far as like,
counseled properly,
Yes, yes, yes. I was gonna say something else when you said that, and I forgot. I don't know. Okay, so that's the big thing with this. Time matters, your access matters, and then again, making sure that you're letting them know if this has happened already, there's nothing I can do. And then if you do see that they have a viable pregnancy, you're not gonna implant something into anyone, okay? This is just more of an FYI for you, not gonna test you on this, but this is just telling you if you have prescribed one of these to your patient, what they can do is they can take a certain amount of those pills to equate to what would be a plan, like a emergency contraceptive, okay? So these are the same exact pills that they would take on an everyday basis, but this is saying like, hey, take 4 of those and then you would get the same exact result as if you were to take emergency contraceptive, okay? All right, our other options that we have. Our patch. Remember our patch was the one that you don't see used as often anymore. And the reason why we were looking at this patch was because it has very high levels of estrogen, and so we were seeing more people having a lot of those VTEs, the increased risk of those VTEs. Efficacy is very similar. You would just make sure that your patient is checking that their patch is still there, so that if it fell off, they know that it fell off, because that's where you see the drop in the efficacy. If someone weighs, again, over that 198 pounds, you will see that the patch is not as effective in that situation. Again, studies don't show anything there, so we wouldn't use it because that has an increased risk of pregnancy in those patients with that are over 198 pounds. And then contact dermatitis, I think on y'all side it said radiation or something like that. It's supposed to say irritation. So to avoid irritation, what they're trying to do is move it to different spots that are approved, and we'll look at some of those spots on the next slide. So like buttocks, upper body is kind of where you will see that at, okay? So just make sure that you're understanding that they should be trying to rotate those spots that they are putting their patch on, and check for their patch because it can potentially fall off. Talk to you about that high estrogen content, and therefore that's why you see such a high risk of our VTEs when you're comparing them to like our combined oral contraceptives. These are all of the different areas that they're allowed to place them. So hips, upper buttocks, upper arms, they should not be placing them on their breasts. Make sure that they're understanding that a new patch will be applied every week. For 3 weeks, once they hit that that 4th week, that's whenever they would stop applying a patch, and they will have their cycle or their menstruation at that point, okay? Looking at this, you have the same exact start, so Sunday, same day, quick start options as you have whenever we were talking about our combined oral contraceptives. And this one you see a window of 24 hours, so that's why I was telling you it's very important for them to check to make sure that their patch is actually on them. If it does come off, they can just put on a new one as soon as they see that it comes off. They don't need a backup method, but if it's longer than 24 hours, then they're going to need a backup method to make sure that they don't become pregnant, and that's again for 7 days, just like our oral contraceptives. Looking at your vaginal ring. So your NuvaRing, good option for patients who don't want to take a tablet every single day. Again, they're going to put in one ring and they're going to leave it for 3 weeks. And then they take it out, and then that's whenever they'll have their cycle. They throw that ring away. Whenever we're talking about a NuvaRing or a Ring, they throw it away. They should not be using it anymore after that 21 days. If it does come out or they realize that it is no longer in, they only have 3 hours. So if they put it back in, or if they insert a new one within that 3 hours, they're okay. If it is over that 3 hours, backup method for 7 days. With this, you see that we're not worried about an increased VTE risk, and we do see that if someone has a BMI that is over 30, that the efficacy of our NuvaRing does go down. With this, some people will ask you if they can wear a tampon while they have in their NuvaRing. The answer is yes. The reason why someone would do that is if they have spotting, or if they just started to take it, they could be potentially bleeding while they're on their contraceptive. So yes, they can do that. Just make sure whenever they take the tampon out that their NuvaRing doesn't also come out. And then the other thing that some people will say is, do they need to take it out during sex? The other answer for that is no. You can leave it in during sex, but if someone wants to take it out, they are more than welcome to, but they need to clean it before they put it back in, because if they just take it and put it on the counter or put it on the top of their dresser and it's dusty or whatever, and then they're taking that and they're putting it back into their vagina, infections and all the things. Some people, I'll also tell them, like, hey, if you want to take it out and rinse it off, you're more than welcome to. Do you have to? No, your body cleanses itself. So again, that is up to that patient on if they want to take that out whenever they take a shower. So those are like the common questions that you may typically get asked. Just make sure if anybody is removing it, that they put it back, okay? And they only have 3 hours. The longer they wait, the more likely they are to become pregnant. And then we'll do this one and then we'll go to our break. This is your vaginal ring, the one that we had for the year. So your Anavera is the brand name of this. So this is that new 4th gen progestin that's combined with our ethinyl estradiol. And so this is the one that they will leave in for 3 weeks and they take out on that 4th week. But they are going to put this away in their pouch. So they're going to clean it off, like mild soap, water, they dry it off, they're going to store it in the pouch, and then they're going to use the same ring. Okay, so this is different than the NuvaRing, because the NuvaRing, I use it and I throw it away. This one, I use it, I clean it, and I put it away, because I can use this for up to 13 cycles. Okay, so 3 weeks in still, and a week off, but now instead of throwing it away, I clean it and I put this one back in again. And I do this every 3 weeks, and I take it out for a week, every 3 weeks, take it out for a week, up to 13 times. This, you see the time has changed, so they only have 2 hours that they're allowed to have to remove this. If they get over that 2 hours, then they're going to need a backup method for the 7 days. This is just showing you how to insert the ring. The big idea here is that there is not a wrong way for them to insert the ring. They can lie down, they can sit on the toilet, they can stand up. However they need to get it in is what they're going to need to do to get that contraceptive there. Most of the time we'll have them pinch in the middle so that it can kind of bend, and it bends very easily. And then whenever they insert it, it opens back up once it gets inside, and then it stays there. So that's why, because it's like this, most people you don't need to take it out whenever you have sex. So that's why we typically tell people, like, leave it and you're fine. When y'all come back, we'll go over our depo. So when we look at our Depo-Provera, you will hear it also called DMPA, and we use this abbreviation quite a bit, DMPA, so you'll see that. This is our IM/Q1 that we can give. When you're looking at this is the one that I told you kind of hurts. So again, they only have to come in once every 3 months to get the injection. Make sure that they're not massaging it, but that they do keep moving around, because the longer that they stay like stagnant and not moving, they're more likely to feel like the pain from that injection. And it does hurt for maybe 2 or 3 days. What we're also worried about here, you'll see that some people will have that irregular bleeding, and then depending on the patient, over time it could again go away to where they do not have any bleeding at all. This one, I want you to pay attention to the delay that they have in the return of their ovulation. So if someone is trying to become pregnant soon, this is not a great option, because once they stop taking the injection, they still have to wait. Depending on the patient, some people, they say that they can see a return to fertility in about 10 months, and then you have some that are at 3 years. So we ended at like 2 years or 24 months on average of what you can see sometimes for that return to ovulation. So if I told you that I wanted to become pregnant in a year, this is not a great option for me, right? Because it's going to take at least 2 years from the time that I stop taking this injection for me to actually try to conceive. Okay, so the older that someone is, and older we're considering 35. So if somebody is over the age of 35, you're definitely watching out, right? Because they're already on a time crunch at that point. Looking at our advantages, low failure rate, because they have to come in, they're going to get that injection, the medication is working in the background without them having to do anything. You don't have a whole bunch of estrogen side effects in it. Great option for those patients who are sensitive to estrogen. Over time, you can see that I'm having lighter periods and not bleeding as heavily. And then also you see that we get the benefit of having a decrease in the in vitro oral cancer that some of our patients can potentially experience. So that slow release over time is why we get the benefit of not having to continuously go in to get those injections. Some of the weight gain is going to be that the big disadvantage. On here you see where it still says 18 months. Make sure that you change that to 24 because that time frame has gone up as we've done more research. I thought I fixed them all, other than this one. So make sure that you put that up to the 24 months as well. Again, remember, the longer that they are on this, the more likely they are to see that decrease in the BMD that happens, okay? So please, 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 please change your 18 to your 24, and remember, weight gain and that decrease in the BMD typically happens when they're on it for a longer period of time. I may, because of, again, the decrease that you have in that blood loss, I may see to where my cycle completely goes away and I don't bleed at all, or I can have spotting that happens every now and then because I've decreased it so much, and it could be irregular spotting. It can happen at any time, okay? So it's a benefit, but it's also not a benefit because if I randomly start spotting and I wasn't prepared, that's gonna be a little bit of a mess if I was that woman, okay? So that's why you see that as a disadvantage. Do not use longer than 2 years. That is a recommendation, and a lot of people who use this medication definitely use it over 2 years. So that's why you're, again, watching out for these side effects that we talked about. Make sure you're getting those bone scans if they're complaining about any of those types of side effects. If you start to see that they are wanting to become pregnant, again, just pull them off. But that weight gain also, again, bless you, you're likely to see that there. So we recommend 2 years, but we do see some of our patients who are on this well over 2 years. This is your IUD or your intrauterine devices. These are going to be those T-shaped devices that we have recommended in women who have a history of or who have breast cancer. If they're far removed from it, then we are not greater than the 5 years, then we can go ahead and we're not worried about their breast cancer history at that point for this medication. Make sure that you're also looking at a patient who doesn't have any type of underlying diseases or any type of abnormal anatomy, because you have to worry about the placement of this to be effective and for it to not get dislodged. So we are worried about that. Your ectopic pregnancies, pelvic inflammatory disease, those are things that we are definitely on high alert for, but you can also see that we want to avoid placing anything in that area if they have a history of that. If they have heavy bleeding, you can use some of these, specifically your Mirena. They have an indication for us to use it for a longer period of time to help specifically with bleeding. If they want to try to not be pregnant for a long period of time, these are great options. We talked about that already before. They can't tolerate the estrogen because, again, this just has those progestin activity in it. When we talk about these IUDs, some providers look at this, some people don't, where they're saying they want to make sure that that person has had at least one child, right? If I tell you I never want children, I mean I never want children, and I ask you for an IUD, you can't be like, well, you can't have it because you need to at least have one child. I'm telling you I don't want kids, right? So this is kind of one of those things to just kind of take into consideration. The idea behind this is, let's say something happens and something goes wrong and now you can't have kids because of, hopefully not, the placement of this went wrong and now you have scarring or all these other things and these complications to where you can't have kids. So that's kind of where the idea behind this was. But again, if I tell you I am absolutely sure that I don't want kids, then you don't have to say, well, I can't place this because you don't have at least one. Okay, I'm telling you I want none. Advantages, effective, don't have to worry about it. We have two different options. You have your copper IUD or you have your progestin IUDs. When you're looking at your copper IUDs, again, this is like very rare situations that we're using it for your patients who can't tolerate any hormones, or if we're using it for that emergency contraceptive aspect of it. Looking at your progestin IUD, again, we have different indications depending on the manufacturer, but you can see that these are going to help with our bleeding and all those types of things when we're looking to assist our women. Disadvantages, those abnormalities that I told you, so making sure that their anatomy is normal, making sure that they don't have the history of that ectopic pregnancy or pelvic inflammatory disease is going to be very important. When you look at this copper IUD, which is another reason why we don't love it, you'll see where some of your patients will have heavier cycles, which is not typically what we see when we're giving people IUDs, but you will see that sometime when we're looking at our copper IUDs, and then looking at your progestin IUD or your hormonal IUD, before they start to see that decline in the heaviness of their cycle, sometimes people will randomly spot during that time as well. Okay, so just understand that we'll have a lot of variations when we're talking about the first 3 months of any type of contraceptive. Looking at your copper IUD, we only have one Paragard, no hormones, and then remember that you're likely to have that heavier bleeding whenever they have their period, and they can also have more cramping whenever they have their period. So this is just working by, as hinted by the name, the copper ions are trying to say, hey, that sperm can't move around anymore, and it's trying to make that environment not be a great place for the sperm to get to that egg. Again here, see that it's not interfering with ovulation, not an abortifacient, can remain in for up to 10 years. After that 10 years, if they want to have it replaced, they can have it replaced and you can put in a new one. Contraindications all kind of make sense. The big one that I want you to remember is that if you are suspecting cancer, if they're allergic to copper, you shouldn't be using these. If they're pregnant, you shouldn't be using these. And then make sure that you remember you're going to have to put this in, so healthcare provider is going to have to insert it, and then that they do have immediate return to fertility as soon as we take it out. So that is a good benefit with these IUDs, but again, not one that we typically use. For the most part, you're going to see that we're going to use our progestin or our levonorgestrel type of IUD, several different brand names, Mirena, Loletta, Kylena, and Skyla. What these are doing is essentially preventing that implantation from happening, and then trying to, again, make the vagina's environment not compatible for sperm to try to conjoin with that egg. Looking at our contraindications, same things that we saw before. So if you think that they have any type of infection, pelvic inflammatory disease, any abnormalities with you being able to place that IUD is what we're worried about. If they're pregnant, they can't have an IUD either. What I want you to look at is the bold things. So remembering your brand names are going to be kind of key here because they have different durations in which you can use them. So your Mirena, you have 5 years. If you're using it for menorrhagia or that abnormal heavy bleeding that someone can have, that's the 5-year indication, but you can use it, leave it in for up to 8 years if they're using it for contraceptive purposes. Okay, so if I'm just worried about heavy bleeding, I'm at 5 years, and then you'll have to replace it. But if I'm trying to prevent pregnancy, I have 8 years. Loletta, you see also 8 years. My Skyla, this one I can use for up to 3 years, and this is only for contraceptive purposes. And Kylena, 5 years. Again, that's also only for contraceptive purposes. So the only one that you have that you're using for heavy bleeding is going to be your Mirena, and that one is cut off at 5 years, and then you'll have to replace it again. So 3 to 8 years is your typical range for how your IUDs are going to be working, except for your copper, that one is 10. Looking at your implantable hormonal contraceptive. So when we're looking at this, you have your Implanon and your Nexplanon. This is that matchstick size rod that they're going to place into the arm, and that's going to slowly release that progestin out into their body. You see different hormonal levels. I don't need you to remember any of that at all. I want you to remember that it is good for up to 3 years before you have to replace it. Okay, so remember the name, remember that this is an implant. This is not the same thing as the IUD. The IUD and the implant are not the same thing. Okay, so implant, your mechanism, progestin is being released over a slow period of time, and that I can have it in for up to 3 years. When I'm looking at this, maybe less effective in my patients who are overweight. So again, if that BMI is greater than that 30%, we're worried about that because of the way that they've done the studies. Okay. Adverse effects, very similar. The only things that I want you to also remember is that they have a potential of having scarring in that area, and a lot of patients will tell you that they can feel that implant under their skin. So just make sure that you're kind of remembering that. Some people will have difficulties whenever they try to, and not a lot of your patients, but when you try to take it out, sometimes it may not be in the exact place where it was placed. You can have where sometimes they break, but those are just very rare types of complications. So if you have a patient who's coming back like, hey, I'm having pain where my my implant was, then that's time for you to kind of explore and see what's going on. And if it's still in the right place, then that is not broken. Adverse effects that we have, breast pain, tenderness, these are the same things that we talked about before. With any of our contraceptives, if they're dealing with hormones, your copper contraceptive is the only one where you're not going to really see these same exact side effects that you have. Nausea, vomiting, these are just a recap of the big things that we talked about. Remember your black box warning with your CV events and their increase if someone is smoking on top of that. And then looking at your patients who have diabetes, you can see that this is worsened whenever they are on contraceptives because it can make them have intolerance to that to glucose. Okay, so those are bigger things that we're looking at. Remember that you're likely to see a lot of spotting and discomfort immediately after placing an implant or an IUD, and that we will see that kind of subside over time. Okay. I know that's how I feel too. I know how everybody feels because I see y'all's face, and I am in agreement with your faces today. But I also looked at the schedule, so if y'all can give me 20 minutes, I will, no, 10 minutes, I'll start the steroid lecture, we'll finish it on Monday, and then we'll do our further hormone lecture on Monday because we're virtual. And then that way we can still finish. I'm trying to give y'all a day back because I know y'all have an exam for next Friday. So I'm trying to finish earlier. So give me till 2:30 and let's open our steroid lecture, and then we're not going to finish it clearly in 10 minutes, but at least we'll get the background stuff out of the way. Okay? So 10 more minutes. So our steroids, we keep touching on them, we keep talking about them, so that's why this is like going to be one of those ones that we kind of knock out pretty quickly. ELOs listed here, and then just a quick background. So we have corticosteroids and we have adrenocorticosteroid. This is just telling you essentially where they're coming from, right? So the adrenal cortex and their synthetic equivalents is like me saying a corticosteroid or a drug that has been made, we'll say that it's a corticosteroid. If it's coming directly from my body, that's where you see adrenocorticosteroid. So just terminology, and you'll see these kind of used sometimes interchangeably, even though that's not exactly the correct thing to use. Then we have our glucocorticoids, and then you have your mineral corticoids. What I wanted to point out from here is that your glucocorticoids are again helping with your metabolism, your immune function, and then your major glucocorticoid that we have is our cortisol. So that's why you see the CO underlined and glucocorticoid, because cortisol is your main glucocorticoid that we talk about. Okay, so remember that. And then your mineral corticoid, again, this was the one that was pertaining to like how my body was going to respond to that sodium retaining function, so my water, and that all of that imbalance. So when you look at this, remember AL is highlighted here because your major mineral corticoid that we talk about is going to be your aldosterone. And so you have AL in your mineral corticoid, and you have glucocorticoid has your CO in it for your cortisol. Okay. This is just telling you, hey, we have cholesterol. This is very important for us to build corticosteroids. Looking at some more of our physiology that you have, this is just FYI, so you can label it as such. We're going to talk about our HPA axis, which is dealing with your ACTH and all that stuff that we've kind of already talked about. So when you're looking at this, remember your hypothalamus releases your CRH to then stimulate your anterior pituitary, which releases your ACTH. Then that stimulates your adrenal cortex and says, ha, here's some cortisol. And then cortisol, once this builds up to a large amount, we'll say, all right, shut it off. I don't need it anymore. So essentially what I'm saying, when we're using some of our medications, we're replacing this cortisol. So that's why you'll see when we give steroids, we'll try to taper them, especially if we have them on. We'll start with maybe a high dose, and then we'll start to decrease that dose over time to try to make sure that we can let that person's HPA axis recover. So this is a lot of why when we're doing our steroids, we have a taper, because the body is like, cool, you don't need this from me anymore because you're giving it to me from an endogenous source. So you don't need me, so I'm going to stop. And with these levels, all of this is shut down now. So whenever I take them off of it, I have to slowly get them back on it. I have to make sure that I'm mimicking what the body would typically do when I administer those doses, so that my patient can respond well whenever I do remove the steroid. So that's why we don't like to give it for a long period of time. So our glucocorticoids, our main one that we were looking at, again, is going to be our cortisol. So when we talk about our glucocorticoids, again, we've already said that we have ACTH, which is a very big key player in us getting the amount of cortisol that we need. And then you have your corticosteroid binding globulin, or your CBG. So when you're looking at your ACTH, this deals with the dosing and when you're going to tell your patient to take some of your steroids. It depends on if you're giving them a dose pack. If you give them like a Medrol dose pack which has steroids in it, typically we would start with a very high dose and we're then tapering it over time. But because we're tapering it, we're not really worried about what time they take it. If we are not tapering it that way, and they're taking the same exact dose every day, like a burst that we would use for asthma conditions, things like that, you want to try to tell them to take it in the morning, because normally you'll see your ACTH levels peak in the morning, right? So that's typically why you'll have us try to, when we dose a corticosteroid, we're trying to make it be as close to what our body would naturally do. So that way, when we remove that steroid, their body is still going to do something. So when we give our medications, and even in a dose pack, we'll do it sometimes after a certain meal. We'll say like after breakfast, or after supper, or after lunch, or right before they have lunch, because that's typically when we'll see our ACTH being at a higher level. So we're trying to mimic that natural cycle. When you're looking at your CBG, this is what is going to bind to our steroids. So if you think about an increase in CBG, that could be caused by like estrogen. You'll see that in some of your patients who have, if they're pregnant, you're going to have less of your free glucocorticoid, because remember, now they're bound, because I have a lot of corticosteroid binding globulin. So that's all this is saying. Estrogen administration in pregnancy will increase your CBG levels. And if you have hypothyroidism, or if there's some type of protein deficiencies to where you can't make this globulin, you'll see a decrease in your corticosteroid binding globulin, or your CBG. Okay? So more free glucocorticoid, your body is going to stop making cortisol because it has too much, that negative feedback system. So just think about how that is going to play into your levels of your CBG. Okay? CBG levels, when they go up, when they go down, if I have a lot of CBG around, then more of my steroid is going to be bound to that CBG. If I don't have a lot of CBG around, I now have more steroid that can float around and have action in my body. Okay? So bound versus unbound. Looking at my mechanism of action, so essentially, remember when we were talking about these, we were saying, hey, these deal a lot with metabolism, they deal a lot with immunity. So when we're looking at our glucocorticoids, they're going to bind to the receptors to get those actual effects happening on those target organs once they reach them. So this is all about, can I get to that target organ and am I reaching it? You're wanting to do and give the lowest dose possible for the shortest amount of time with any steroid that you use, because of that HPA axis suppression and because of the nasty side effects, which we've already seen. Looking at these metabolic effects, again, you see that you can have that more carbs and breakdown of the protein for energy, so that increase in your gluconeogenesis, your hematopoietic effects. When you're looking at that, think about your immune response and your inflammatory response. That will be decreased. So what does that mean? That means that now my patient can have more infections happening to them, right? And that's why we say the longer that someone is on steroids, the more likely they are to have that increased risk of infection. And then when we talk about like autoimmune diseases, this is good, because then that's going to dampen that person's response, their body's response to attack itself. So that's why you'll see us use corticosteroids in patients who have autoimmune diseases, because we do want to stop it from attacking itself. We want to dampen that response. And then our anti-inflammatory effect is the big one that we know about, right? And that's trying to say, hey, I want to stop all of these different, the different cascades that we talked about happening, and we had two different routes in which our inflammation could occur. This is essentially trying to say, hey, can I stop all of those lymphocytes, the macrophages, that whole immune response, can I shut it down to decrease the amount of inflammation that that person is having in that area? And so, again, big thing for you to review is gonna be looking at this and where our corticosteroids work. So remember, we had that stimulus, that membrane gets disturbed, and then we're trying to release phospholipids to whatever that site of injury was to try to repair it, and that's when we see a lot of the inflammation. So with our corticosteroids, they're trying to say, hey, if I can stop this phospholipase, I can stop the arachidonic acid from forming, and therefore I can decrease my body going into either of these pathways for inflammation. So that's how I get my anti-inflammatory effect, which is the big reason why we are using our steroids. And then we'll start here on Monday.